Next speaker will be Dr. Anindya. He will be joining online. So he will be talking about UBE TLIF. He's an expert in the topic. So I invite Dr. Anindya.
Morning everyone, I'm Dr. Anindya Basu. I'll be presenting my lecture on unilateral biportal endoscopic TLIF. Um, so if a patient like this comes with claudication left-sided radicular pain and failed conservative treatment with a MRI that shows significant stenosis at L4, L5 and a dynamic X-ray that shows instability, would get a surgery like this most often in my practice. This is a minimally invasive TLIF through tubular retractor. This surgery is very fast in my hands. This surgery gives very good results to my patients. I've done more than 300 of these surgeries, and this is my real workhorse. But the question is, times are changing. Surgeons are posting minimally invasive surgical videos in social media showing off their excellent results. That got me confused whether I should do something new. And I decided that it's time to make a change. So the basic concept utilizes uh, in UV, it utilizes the two portals that are made similar to that we used to do in knee arthroscopy, where we do the portals and we reach the space called sound space, which is basically a potential space that overlies the lamina and underneath the muscle multifidus. So we reach that space, we dilate that space with saline, and we actually work in a potential space. The surgery is done in that potential space without harming the multifidus. So in that way, you can call it very ultra minimal invasive. So the interfascicular space, which contains fat and loose areolar tissue, that is called sound space, the actual space where we do the surgery. And this picture by my friend Ashwin Khandeke depicts a sound space very nicely, where we can see that what we have done is we have actually lifted the multifidus off the lamina and the interlaminar space, and we are working in that potential space created between the lamina and the interlaminar space with the multifidus at the roof, and the working space is created by the saline. So was it too difficult for me? The answer is no, because the endoscopic view is similar to that of posterior microscopic surgery, and the standard spine instruments are inserted and used. So these are the setup that I need for my surgery: dilators, RF, knee arthroscope, same as that you would use for your knee surgeries. Although I work in a neuro institute, but these microscopes are used for neurosurgeons for the pituitary work as well. So I use a 0-degree scope, and with that an RF plasma setup, as well as a arthroscopic drill setup, or you can use any drill which has sleeve as well. The standard instruments like kerosene punches, pretty graspers, and all these forceps are that we use for microsurgery or open surgery, or can be used in endoscopic surgery as well. So the video where you see that once I landed inside the sound space, actually I'm landing on the bone. So it is actually I've lifted up. This is the first step where I've landed correctly in the sound space, and you can see that I've landed on the bone, and we've lifted up the multifidus and the saline, actually creating that space where we work and will continue to do the rest of our surgery. So that way, the muscle damage is very less, I would say. So this is another video which shows the rest of the steps where we use the RF to create the space. We start drilling the lamina, and within in endoscopic fusion, what we do is use a lot of kerosene punches, take away the bone, because that we would use as bone grafts. So this is what we have done. You can see that we are using the RF to actually delineate the inferior articular process, and we going to the facet capsule. I'm using the ultrasound scalpel take away the inferior articular process as a whole that we can use the bone graft. After that, we carefully take away the ligamentum flavum of the thecal sac. And often in stenotic cases, there are a lot of adhesions and there are a lot of strands between the dura and the ligamentum flavum, which have to be very carefully dissected off the ligamentum flavum of the dura. And in cases where you're doing this surgery, this can be a bit faster, but in with stenotic, where you're doing stenosis surgery, you have to be slow and carefully take off the ligamentum flavum of the dura. So here you can see that I'm doing the end plate preparation, and the amount of magnification that you can see in this surgery is phenomenal. So uh, I routinely do the minimally invasive TLIF using a pentado microscope, which is quite a powerful microscope. But even with that, you cannot get such beautiful view of the end plates that you can get in uh, endoscopy. There you can see it's absolutely bloodless. You can under direct vision, you can take away the end plate cartilages, and you can actually do a very thorough end plate preparation from end to end. You can take away, you can go as deep and as possible, and you can see the anterior longitudinal ligament as well if you put your scope inside. And the image on the right side, you can see that under the pentero microscope, this is what we see when we are doing a minimal invasive TLIF using a tubular retractor. So compare these two views, and you will see that amount of meticulous end plate preparation that is possible in endoscopy is phenomenal. So again, another view where we see that the very good subchondral bone has been exposed. The damage to the subchondral bone is very less in endoscopy. Because you do the end plate preparation under direct vision, you are just likely to damage the end plate, and that causes less subsidence. So you can see in this view the traversing route, the exiting route, and you can see the opposite side as well. So the end plate preparation is something which is a real standout feature of endoscopy TLIF. This is the exiting route that you can see. So it gives you a very good vision of the exiting and the traversing route as well as the end plate. That makes makes you achieve the end points of your surgery, which is excellent decompression, good fusion. A very predictable feature for this kind of a procedure. So yeah, I've done in a few cases single-sided fixation as well, where I'm very happy with the cage placement, the amount of lordosis that I could achieve, the amount of fit that I could achieve, and it's a TLIF surgery is only basically you do it with 2 stab incisions, and the patients are very the pain that you get in this patient is very less compared to what you get in open TLIF or other forms of lumbar fusion as well. This is the post-op X-ray. The posture of the surgeon is another important thing. But this is what I'm doing the end of the minimally invasive TLIF. I have to bend back, the microscope has to be positioned, and the assistant surgeon has no clue what is happening because he can't reach, while I'm operating on the opposite side, he can't reach the eyepiece of the microscope. So again, better very excellent ergonomic for the surgeon. You can see excellent decompression that we could achieve with doing endoscopy. The assistant and the nurse, they also feel a part of the surgery because they're very much involved in what is happening, and they can be ready with their instruments once you need them. So you can see that by going towards one side, you've done an excellent decompression of the traversing route on both sides, and taking away the pressure of the lateral recesses on both sides. So these are the clear-cut advantages: more magnification, more mobility of the surgeon, working space is much more, and you feel comfortable that you're working in a bigger space compared to what you'll be doing inside with a tube. And hydrodissection is what pushes down the dura and makes your life easy. Even in stenotic cases, you can pass your kerosene very easily between the dura and the ligamentum flavum. Bloodless field, obviously, whatever blood that that oozes is washed out, and it gives you an excellent feel for while operating. And end plate preparation, as I showed, is a big advantage of this procedure. And as we are working in a potential space, even not touching the multifidus, the amount of muscle damage is significantly less even compared to tubular surgery, where we have to, with our cautery, we have to take away a bit of muscle that comes in our way on our way to reach the bone. So again, this is over-the-top decompression. This is a contralateral traversing nerve root that you can see. Such excellent vision of contralateral nerve root is possible only with biportal endoscopy. But on the right side, I'm operating with cube. I'm doing a minimally invasive T-lip, even with the pencil microscope with high field magnification and with tilting the table. I'm trying to concentrate on the opposite side. But you can do a good decompression on the opposite side with the microscope. You have to push the dura down a little bit with your suction, but the clarity of vision and the ease is not the same as that of endoscope. So again, hemostasis check is a very important thing. You can see that at the end of the surgery, when I stop the irrigation, there is no bleeding at all. And if at all there is an ooze, we can go and check that with or control that with our cautery. So the hemostasis achieved is excellent in the surgery. Uh, and there are multiple advantages of monoportal as well, because the scope is much very thin and it can reach all the nuance, all the corners, nook and corners of the spinal canal compared to the big scope that you have for monoportal surgery. With which so monoportal I feel is great for single level disc or disc surgery. But if you're going for stenosis surgery or if you're going for fusion, biportal has much significant advantages over monoportal. And cost is obviously a big thing, because in monoportal, if you break an instrument, you're going to pay heavily for it. So these are few of my cases. Instability, where you can see done an endoscopic T-lift. Another case, quite a high grade slip. You can see it's almost grade 3, but we could manage a good reduction and endoscopic T-lift. Another case where quite significant stenosis. These are grade 4 stenosis with a facet joint cyst, and we could achieve a very good endoscopic decompression and fusion in this case. So again, other lytic lysis at L5S1, we could do it endoscopically. So high grade slips and as well as very severe stenosis are not contraindications for endoscopy as popularly thought by surgeons. And it's only with time, with the number of cases that you do, you get the experience and the confidence of venturing into the tougher surgeries like high grade slips and severe stenosis. This is one of my cases. I used a reduction. Again, a high grade slip, a grade 2, almost going to grade. I used a expandable cage. This is one of my cases which failed. Since then I've been very skeptical about using expandable cages, because they can cause the end plate damage, as well as the bone graft that you can put in through them is less. So I'm very skeptical of using expandable cages, at least the ones that were available before, which had very little scope for bone grafting through the cage. So these are a lot of papers which shows the endoscopic T-leaf is gaining popularity, as well as less invasive than MIS T-leaf. A lot of meta-analysis are present, and RCTs are also present, which shows endoscopic T-leaf is not inferior compared to MIS T-leaf, and has significant advantages in terms of clinical outcome in certain parameters. So literature is becoming robust with time as we gain more and more experience and confidence. And thank you very much for your patient hearing. And these are all my mentors who have guided me the part of the spine surgery as well as endoscopy. Thank you.
Nice presentation, Anindya. Anindya, are you able to listen to us? Anindya, getting me? Nice
Am I
talk,
audible?
Anindya. Have some queries. I will be
Yes.
very happy to take them. Missed you, but at least we are
Yeah.
able to see you.
My sincere apologies for not being able to be there, but at the same time, want to wish everyone there a very good afternoon. And I sincerely, kind of miss being there. Absolutely.
Nice, Anindya. But one point which Anindya stressed when we had extensive talks today. Only thing what I feel is all minimally invasive procedures are minimally invasive to patient's anatomy, but maximally invasive for surgeon's anatomy, especially
Yeah.
for the spine. But this UBE, it minimizes that surgeon's invasion also, because
Yeah.
ergonomics are well maintained in this. Uh, First, when I came to you, that's the first thing which attracted me, actually. So microscope, you struggle a lot, train your back a lot, but in
Yeah.
UV, you need not, because the scope
Yeah.
moves. You need not move much.
Yeah. So basically, the surgeon's posture is something which I emphasized upon, because if you're doing a microsurgery for a long duration for anything, maybe for for a lumbar spine, for a cervical spine, for tumor, for even for neurosurgeons, prolonged brain surgery, we all know that if you have in a particular posture, if you're straining your neck, keeping your neck in a particular posture for a long time, you descrub, you get a stiff back, stiff neck. So that is something which you don't tend to have in UB. You are comfortably placed, so it is very important that you are, as a surgeon, you are comfortable doing surgery. You do it like any other endoscopic surgery where you do it like playing a video game. So posture for me is another big big important factor for considering UB. Posture of the surgeon is an important factor of considering.
Mr. Kaninja, go to the. Who wants to ask you?
Yeah.
Nice talk, Dr. Basu. Dr. Rege from Pune. I
Oh,
just
hi,
want,
sir. Yeah.
Right. I just wanted to ask you that what is your comments on using these large cages, which a lot of surgeons are using compared to the standard TILIF cages which we use in mini TILIF?
Right, sir. So my like I haven't used uh, the the large cage as of my experience. I haven't used them because I've been very I've been getting consistent results with the smaller cages that we have been using for TLIF in my MIS TLIF and my open TLIF cases. So why not just translate the same technique into or the same cage? Why not use the same cage for my endoscopic cases? So, and in as far as my endoscopic cases are concerned, there also have been no apart from occasional cage failures and all that we would have. We won't I haven't experienced any significant change in fusion rates or significant decrease in efficiency of fusion. So I'm quite happy with the standard one cage technique. Even I don't use the two cage technique. It increases the cost to the patient as well. So I'm happy with one cage. I haven't got any significant complications from them.
Yeah, I completely agree with.
Finally, this is the final topic for this session. So I invite Dr. Nikun for UV surgery in Nepal, where we stand, and
Thank you. Have a great meeting. See you next year.
Uh, Good evening. And coming to the last presentation, and last presentation because after that after this we have some kind of session, not presentation. And my presentation would be rather than a present ending of the conference, and it is kind of observation of what where we are currently in the scenario of the. So as far as I remember, when we talk about spine surgery, it's somewhat around 1819, 2018-19 endoscopic spine surgery started coming into discussions, Nepali neurosurgeons and spine surgeons. And the start of the harbinger of spine surgery around Kathmandu and in Pokhara. So Dr. Balgopal started endoscopic spine surgery in Manipal, and similarly we have Dr. Deepak Shrestha here, started endoscopic spine surgery in Dhulikhel. So in those years, they were the pioneers of endoscopic spine surgery, particularly UV surgery in Nepal. So first endoscopic spine surgery was actually performed as a guest faculty by a foreign neuro, and that's how we began with, by a formal training from them, attending conferences and workshops and training into animal model. So somewhat around 1819, the first if that occurred was in Manipal, and Professor Malcolm Pistonji, and we have the juggles around all the UV surgery in Nepal. Dipankar, Dipankar sir, he came, brought Professor Malcolm, and we had a conference, a live operative case, and first endotelief was done in Pokhara. I happened to be there, and I got to learn from them, Balgopal Karmasare and Professor. And then we started having animal labs workshops. So the most important thing, how to overcome your expertise in resource area, and in a place where at the beginning there are no more neurosurgeons that you can go and ask help from, is that you get into animal lab, train and retain yourself again. And this is what I got from my mentor. And I is where Professor Dr. Balgopal Karmasare and myself, we used to take goat models and pig models in OT, and we used spend hours and hours practicing in it. And it's his determination that we gradually had success in UV research. So animal lab is where you shorten your practice, your expertise, learning curve, and then you all, apart from that, you also need either mentorship or proctorship. Somebody has to tell you how is it done, it is done. Somebody has to tell you what are the nuances. Somebody has to tell you what exactly difficulties and obstacles you are going to face when you are going to do surgery. And in my course, what I learned is you not about only the surgeon doing surgery in the patient. It's about training your whole team. It doesn't mean that only you know how to do UV surgery, you can start it right away. You have to have ground staffs, the supporting sisters, the housekeeping staffs who are handling the water pump if you have one, the RF, the drill, and the line irrigations. These all things needs to be properly trained. So you have to get a proper mentor or a proctor who can help you to start these practices. Go to their setup, see how things are done, and then you can. So this is how shorten the learning curve. There have been papers who has been talking about how many cases you can do before you claim that you have a well versed UV surgeon. So they have said about around 35 to 40 that you need to do before you are well versed. But at this time, what you can do is you can practice in a model and then shorten this number in real scenario. You can start doing UV surgery immediately if you have a good hand-eye coordination, if you can do a perfect triangulation animal. Now, the present scenario is that going back to 2018 and coming back to 2024 and 25, we have got multiple centers where UV surgery has been done. Right from the western region where Nobel Medical College is there, there is orthopedic surgeon called Dr. Ajay Mohato, and then in the center there we have Gillick Hill. They have built a team who has been doing UV surgery. I've seen the presentations today. There is Kathmandu Medical College, KMS. Professor Papa is heading that unit. UDM Dinas, we have got full team in operating and coming up with UV surgery. NES as young team coming up with UV. And BNB is there. Sri Bendra Hospital is there. Medicity, Western Pokhara, we started with the Nepal CMS. We have got talks with Dr. and even in Nepal. So a lot of centers have started doing UV surgery. Now, what is the benefit of it? The benefit is that you can have help, can have help, can talk to colleagues who are experienced. If you have problem, if you have complications. I do remember when I had a first dural tear, I had to ring up and ring both of them because I was worried. Everybody, so I had to call them up. I have to ring them up, and whatever you discussed today was the exact point. Told me you have to map it with a nerve hook or a bulb probe or 5 millimeter, because once you get inside, you'll not be able to find the red. I was assured, came back, nothing. So till that, nothing has happened to that has occurred in my practice. So now, if you have a lot of neurosurgeons in your country who are doing UV surgery, that becomes a big pool of help for you. You can discuss things and you can take things further from. So talking about my institute in UDM Ninans. So after I trained in UV surgery from Dr. Balgopal and from Dr. Malcolm what we did was we shifted our like we passed on our experience to one by one. Passed one our experience one surgeon, then other surgeon, and to other surgeon. Now we have almost 3 or 4 surgeons who can do UV surgery. Case a problem, I don't have to ring up anyone. I can call my friends right in the and they can give me, and that makes a lot of difference. You have to build up a team. Whenever you are practicing, single surgeons are very tiring. It's very tiring sometimes because and complications. And you have to increase your armory equipments. I didn't go about all the details because talking about instruments, we are talking about steps, we are talking about triangulation, talking about video of discectomies, canal stenosis, everything. I'm telling you, ideology, what is required is for armamentary. The armory inside you need arms, arms that you are going to use to be have to strengthen you. And training and retraining, I'll already told you, never stop training. Learn from Dr. Bal is you not stop training. I always in hunger to learn, always running around places, learn new things. So with age, with expertise, never think that not be always be learning, and that's where conferences and workshops in they are handy. So training and retraining, animal lab is the perfect example. You can see my friend, we have shifted the scam into what is called in an open space where there was the lift, took our equipments up, started training. Whenever there was no case, what we used to do in the beginning is we used to bring a pork, put it in a bucket, start operating. That gives you a beautiful hand-eye experience, coordination of hand-eye and triangulation. This is how you learn surgery. After that, you all are beautiful spine surgeons, well-versed spine surgeons. You can take it, you can sell very easily after that. So what we did was in Basbari, after that we did was we conducted national courses, international courses, conferences, and then we collaborated with our partners in various countries. That's how we shared our knowledge. We had numerous very well known spine surgeons from Nepal and from India visiting us. When they visited us, it was a bilateral learning. I never call it a course. It was a sharing of knowledge. A lot of things they tell me, I learn. My experience gets increased. A part of things like from UB, I give them my experiences. So courses never be named up. Because your neurosurgeons, spine surgeons, please do be centers where they are doing surgery centers. Go there, spend some time, their knowledge is impart some knowledge to other, get some knowledge from them, and that's how you. So these are the glimpses of cadaver courses that we have been holding. We have been conferences. One is by Nathan in Viratnagar. The other you might be well knowing the very same cadaver lab you had studied down there. We had been conducting, and then life surgery cadaver courses, neuro spine surgeons. And this is how where we Nepal stands right now. The future perspective is 3 things or 4 things that we have to enhance on. One is enhancing knowledge. The enhancing knowledge that is only done by conferences, joint courses, international exchange of skills are the most important thing. Here we have a lot of Indian surgeons and Professor Yang from China who they imparted to us a lot of knowledge. We shared some knowledge. Sometimes we go to India, we get every conferences teaches you something, some nuances. Bring some nuances back. Please do that. Do visit conferences, share your knowledge, and enhance skills. Whenever you are doing UV surgery, always know your limits. Start from dissect, like Dr. Sai told. Start from dissect left ones, gradually move right ones, gradually move analyst, go and do over the top under the cave work as and then start doing thoracic, then do cervical, and then do pedural pathology. That's up to you. And then enhance armamentarium, like I said. Your instruments should always be never let your skill be at one level. To increase at explore it, explore. The horizon is wide. UB does not stop at one point. So for Nepal, what we need to do next is we have to collectively help each other enhance in terms of knowledge, in terms of skills. That's why we what we think when we're discussing in developing a skills lab where all the neurosurgeons, spine surgeons from the nation can come together, hold courses, and enhance skills. That's what I think is. And finally, coming to that, what we are doing in our hospital, we've acquired an OAM navigation. I was listening to talk of Professor and Dr. Sai, and I was very much like excited. And then I put up a discussion. That's how I was doing when I did my first. Yes, it was a trial. I didn't need to do with an OAM because it was not a fusion. Fusion with OAM and navigation actually helpful. It does help a lot. But then it was a simple UBE discectomy case. I wanted to try, and it was quite a nice one. You can see the needle, the 3D that I am placing in the spinolaminar junction. You can have a axial and sagittal and coronal view, knowing exactly where you are landing in your ipsilateral recess, ipsilateral facet. You can identify everything. So if you are doing that in TLIF, it will definitely help you fixing the pedicles. That will shorten your time and give you confidence. And like I told you, like Dr. Sai told me that you can suture, I had taped it. It doesn't move much, and a little bit of error, marginal error, doesn't matter if process and discectomy. But please don't do this when you are doing a fusion. Make a midline cut, plate the reference frame in the spinous process. That's very much important. If there is a shift, your pedicular entry zone might have shifted. You might be wrongly placing the screw in. So this is what you can do. You don't need cut. You are using OAM navigation. You can see the reference kept. I have kept it in the wand, RF wand, and as you are moving this, you know where exactly. So and the international collaborations. Always, I told you, expand your horizon. Nepal has come to a stage where we are collaborating well with our neighbors. We are representing ourselves very well in arena. We have got our friends, India and China, and even in other countries who are ready to help us. This is the way to move. Finally, we have created this telescopic spine society with the help of nation. And this is the executive board, and we have planned to develop UB. With thank you all. Anything comments? If there is no comments, now
In the session.
and after this, sir, please.
Well, thank you, Nikunj and Dr. Balgopal. It was a wonderful lot of UB discussions the whole day. And you have summarized it well as to how we should go and how we have been doing all the time. But then this is just a remark to the youngsters who have been listening to this maybe for the first time or maybe for doing it. Please do not join the bandwagon just because of the peer review pressure. Peer pressure can push you to some extent, but then it will not give you a good steam to carry on. Understand the need, because when I started as a microscopic surgeon, I can do everything with the microscope. Then why should I jump for tubular approaches and then Destando system and then UB? Because we felt a need. And that's the whole discussion we have been doing since the morning, is to tell you what is the need, why we actually transformed ourselves from microscope. So until unless we do not understand this need, we will not understand the pressure to change or the need to transform ourselves. To understand that need, this is very, very important, rather than just because of peer pressure, because somebody else is doing it, so let's also carry the flag. Should not be the motto of our inspiration. And thank you, Nikunj, and thank you, Bal Gopal, for getting this society as such. And we all are here to support each other, and please be conversant and come together again. I request all my orthopedic spine friends or also neurosurgeons to come to this community and then try to as much as possible on the and carry this flag forward. Thank you once again.
Thank you, sir. Beautifully summarized. Thank you. Thank you very much for completing my my job. And with this, we end this session. Now, what we'll do. So after this, we have got the Upendra Devkata Memorial Controversies and Consensus session. But because of lack of time, what we are doing is quickly summarizing it now. We have a bit change of last moment change of plan. What we are doing is we are merging this session into one. We'd call up Dr. Sikhar Shrestha, Dr. Sagar Koirala, Dr. Pratyush Shrestha, and Dr. Tej Prakash Dawadi and Dr. Sai Kalyan up in the dais. And we will have Dr. Balaraj Shekhar in the front row, Dr. Amit Thapa in the front row, and Dr. Jitu Thakur. I didn't see you before. Chandra Thakur in the front row. If you can come in the front row. Three of us, five of them, the scenario will be projected by Dr. Suresh Sapkota, and there will be discussion whether monoportal, UBE, or open surgery is better for each scenario. And Professor Amit Thapa, Dr. Balaraj Sekar, and Dr. Jitendra Thakur will be the final jury. Would be the final jury if there is a controversy. If there is not a controversy, the session will be moderated by Dr. Shikhar, and there are panelists over here to discuss. I hand it over to you. Thank you.
Hello.
I don't see him.
Hello. Hello.
Can I see Amol sir? Do I see Amol sir there?
Thank you, Dr. Nikunj. I have a very difficult job of moderating this about microdiscectomy versus B, consensus as well as contradiction. I think by this time, after hearing so many experts talking about UB for last 2 days, yeah, most of us has already, most of us have UB in our mind. And yeah, and I think we have already forgotten microdiscectomy. But then I think we should never forget our root, because the root is microdiscectomy from where we all emerged actually. Uh, Opening the discussion, let's start from the root. For the proponents of microdiscectomy, I think here we have Dr. Sagar and Dr. Patyus. What's your take on microdiscectomy? Will it sustain the pressure of UB over the last 2 days that all are feeling constant?
Thank you, Dr. Sikh. That was a hearing about microscope. At par with, better than the worth changing your practice, worth changing your habit. But for something that is at par, takes time, and you are doing a lot of stuff, not just spine surgery, as well as everything, brain, whatnot. Practice of something which has not yet better than a still microscope.
Thank you, Dr. Sagar. For the proponents of UP, Do you think that the example of gold standard is going to change in time? Is UB is going to be the next gold standard, or still microdiscectomy will still continue gold standard in our practice? What's your take for the proponents of UB?
Yeah, I just wanted to ask him a question. So, my friend, 15 years back, which phone you had? What was the phone?
Yeah, I used to use iPhones. Now I use iPhone 15. But I have not changed to iPhone 17 because if you see
No,
the
no,
marketing
why,
of
why?
the no,
No, no.
I'll just finish your. I
No,
had taken
there,
this.
there ends the discussion. See, from 6 to you have upgraded to 15. That is, there is some evolution. Okay, there is some evolution. So I do agree, but scientifically, if you talk, so you send to take the blood loss and inflammatory markers like PK and even CRP. Compare. The results are far favor in. Okay, the operative time, yes. When you're a good microsurgeon, obviously you can be a good UP endoscopic surgeon as well. And other thing is, the operative time is less, expert hands, the blood loss is less, hospital stay is very less, very, very less. And say other thing, the most important thing, the patient is judged same day or within 24 hours. Yeah, I do agree that long-term results are yet to get established, but no things I think I'm able to convince you. First is your phone, second is scientific evidence.
Regarding the phone, I just have one counter. iPhone came from 6 to 17, but iPhone sales of 7 did not beat sales of iPhone 6. Similarly, sales of iPhone 10 did not beat the sales of iPhone 6. iPhone 11 and 15 were the only ones which had increased number of sales as compared to their predecessor. So it doesn't mean that every new evolution, every new technique is the way to go about. What if something else comes about, and you can do vasectomy even without opening it? Maybe something like they have come in PMS, outer energy that can zap then you will be extinct as well. So you cannot always say that
Yeah,
new evolution is always the better.
yeah, I agree. Then you should have stick to you would have stick to iPhone 6 in that case.
I've come to 15,
That's what.
but I didn't buy
In that
10.
case, in that case, you should have stick to
Well,
6 only.
so what is the main guiding principle if we compare microdiscectomy versus UB? Is there any difference in the guiding principle? Why we are doing microdiscectomy versus why we are doing UB? So, any take proponents as well as opponents? Is it the
Basically,
same, or the guiding principle is different?
the advantages
I'm
like
not
micro.
sorry, I'm not talking about the advantages, but I'm talking about the main principle. Why are we actually in? What are the indications of microdiscectomy versus you, the patient? For example, a patient comes, you want to offer whether either a conservative management versus operative treatment, right? So, is there any difference in indication between the UB versus microdiscectomy for a given condition of a patient? Absolutely.
Previously, so time when analysis that shows that early outcomes are much
So,
better.
so,
Early
so in
outcomes.
the same line, I want to ask, like, is the gazette important, or is the final outcome to the patient important? I'm just playing devil's advocate. I'm not leaning to one particular side. But what is more important? Because there are a lot of listeners, I know, and there are, I think, in the audience, there might be neurosurgeons or even orthopedic surgeons who have not yet started to be in full-fledged way. I know that's the future, but then talking to the main principle, be the nerve root. So principle wise, we all agree that both UB versus microdiscectomy are going to offer the same thing, right? Sometimes I even put example like it's eating rice either with hand versus rice with fork, eating rice with what is the most important thing? Rice, and then filling up your tummy, That is the most important thing, number one. So rather than being gazette oriented, Uh, is it a good idea just sticking to the older technique? What's your take, the UB proponents?
Yeah, if you have gone through my present, I have mentioned of the slides. Taj Mahal. Okay, I agree. You have got good magnification, but at the same time, if you want to see, then definitely it's a good tool. At the same time, you need to master it. Okay? And when you see from very definitely but to micro disc. And there is a theoretical thing. They say that don't get the 3D view. Don't get the 3D. But there is a thing with having the tactile feedback. Your mind, you get to 3D. So when you have this and able to see the tissue, chances of errors. Why you have switched over from open surgery to because of the same way? Yes, we are able to see the tissue from very near. So scientifically and logically, I think from better, better results. Margins of are very low.
There's no confusion with surgery, good magnification of where we are, very good in about the structures. But regarding microscopic discectomy, surgery not around a lot operative. Straightforward. We are just, I accept that need to keep up with the advancement. Probably further is our practice are reasonable, but for microscopic disc, like a clear cut steps into discs level, I think amount of information very much adequate.
What do you think is the complication profile between the two? Like for the UB proponents, do you have like we be more worried while doing UB for the fear of dreadful complications as compared to straightforward microdiscectomy? What's your say on that?
Regarding the complication, yes, there with you. Uh, that is the that tension from clear complication blindness, but even with because of the
Is there any particular way we need to take care of while making the incision in order to avoid increased intraspinal pressure because of accumulation of like the reported complications, as you've said, like retinal hemorrhages have been reported in the literature, secondary to raised intraspinal pressure because triangulation was not proper for fluid to drain out. Is there any technical nuance that you want to share to the audience in order to prevent such kind of?
basically in my practice also I have adequate outflow, make it large enough. Once space educated enough that there is some question of and that has some that itself gets that hemostasis that good just picks up. In my case, there was a position up to 2 level up. I could finish by that time. I didn't have any, not all this extravagation also have. Right.
For Dr. Sagar, since you are working at UDM Ninas, which is my alma mater to begin with, I worked there for almost 2 years. Here we have got, availability of both microdiscectomy as well as you, Dr. Nick, taking the step forward quite well. So residents there, I envy because they have had opportunity this time to observe both the cases. Because what I think as a unbiased moderator is that like we need to switch between cases with ease because sometimes like if the key does not come with a red finger, you need to bend it. In the same manner, it's not dogmatic that okay, one should totally go into UV versus one should totally go microdiscectomy. So for Dr. Sagar, what's your say on incorporation of UB training right from the early years of residency, so that by the time a surgeon emerges out of the residency program, they'll be well versed in switching over from two techniques from microdiscectomy versus you. What's your take on that?
I think that is one of the most important aspect because without learning microscopic discectomy, cannot. I mean, you may be able to do it, but I think it's always better to start with the first step and microscope one. Because in your initial days, if you get lost, have to convert it into approach. Should first begin with microscope. That is why it's still. And as you rightly pointed out, right from our training days, we're at the same. We were not allowed to keep pottery, not allowed to join pottery due to microscope. It should be our lesson. That is how we asked started at a very transfusion requiring patient. That all requiring bipolar. And now that we have both UPE and microscope, the resident gets to learn microscope. That forward if they come a full on spine, they work more on spine. They have the entire armament. Not know which land up. After resident might land up in a or especially in the government might have to even do a open in open sense that is without even microscope everything and you should always be. I would also agree with what Dr. like cannot learn how to do multi-level without learning how to single level as a starting point. Hence their spinal practice start with, but sticking to as a bread and butter and do other practices as well.
For the proponents of UB, what do you think is the greatest hindrance, especially in cases of private practice, for starting UB? What do you think? Like in Nepal, there's a variety of practice, institutional based practice, the teaching hospital, set of private practice where spine cases gets shared among the orthospinal surgeons and neurosurgeons. So as Nikunja presented his case that we should be doing, practice in dummy, that's a different part of the story. But then while doing private practice, you are more worried about delivering, good result to the patient also. And you get limited number of cases, beautiful case, good result. What do you think is the greatest hindrance for UB?
Well, hindrance, you're talking about the hindrance. Do you agree with me or not? Most of the centers have laparoscopy. What it should put unit. Let us think a scenario that we have a laparoscopy, have a camera. So what are you supposed to procure? One, only this, that is the RF ablation. There are several things in the market. Not endorsing that you can get it. The basic spine things, basic spine instrument. You can start the program. I agree. For microdiscectomy, always it is 100% mandatory for everyone to know surgeries. The next step is think the loops. The next step is microdiscectomy. And extension of all these setting up when you compare on a microscope and comparing the establish a definitely the far less at a UB. And hindrances training is one. And I recommend my personal step by step. Step by step. Open surgery, then convention. Second thing is now everything is there. Media have webinars. The experts, the webinars, try to do and these. Then you can knowledge me, and you have done good number of a problem. Start.
Like orthopedic background, had the arthroscope. I have that spine set. I had already started. Actually, I didn't buy anything. Start UV. For buying that proper UV, I have started after the trip. I immediately started that. And it's really extra. That make
For the interest of time, I think we can on discussing for hours and hours or the wrap up. Wrapping up and passing to the final question that I'd like. Next 5 to 10 years down the line, where do you foresee the field going to be invaded by the artificial or the armamentarium that's added to our arsenal versus going to supersede microdiscectomy as the gold standard, the next gold standard in the spine surgery? What do you think?
Is it? Yes.
Well, actually, I'm talking.
We have to
I'm a moderator. I'm not.
Can become a
Okay, so over to jury for
First of all,
final concluding points.
I want to have opinion from the audience about this discussion. Is there anyone who is pro or who is against it?
I have been doing about the evidence. Done at all. So in that study, they not show superiority, but there is no goal. The only I think we visualize our patient. Patient may come from the poor background, but other patient, the surgery and the chance very less. Those cases we can give an option of. So it is really as approach. Now we cannot support or defeat any of the
You wanted to ask some question.
Out. Good evening, namaste everybody. The executive chairperson for Real News. Thank you. Thank you so much, gentlemen. My question to, I don't know if I'm allowed to ask a question. You are about to hear the verdict of the, but my question is, putting aside the cost of equipment, particularly in a resource constrained country like ours, where people find it very hard to pay for good quality service in private sector. I'm just talking about the operational cost of doing micro disc vis-a-vis. Thank you.
Yes, I think Judy should be answering this question.
Really, what discussion has been going on now, UV is really not a very yeah? If you have basic, yeah, it takes time. Time is the constraint. If you have basic arthroscope, if you are, yes, ma'am, if you have to up your level, you have to go more finesse, you have to do more complicated cases. Maybe you have to invest. Not to do basic work, like simple discectomy, may not be as as other monoportal surgery. Definitely, it is more expensive. We can go in a reverse. If you have to do microscopic, again, the discussion is broad. If you buy a microscope, it will cost you 1 crore rupees. But operation cost is not that much. It reduces. These are the main constraints. Who will be at disadvantage in this?
We are
Surgeon will
also
be at disadvantage.
we are also forgetting about Dr. Nikunj.
Yeah, at
It's
least
not just about the RF and stuff, but it's also about longer duration of anesthesia, means longer duration of all the anesthetic agents being used, which is also costlier.
That's, if you are looking at the initial learning curve, yes, it's 1 hour, 2 hours. If you're talking of discectomy, simple discectomy, okay, like apart from you setting up the patient and then intubating, let's say about 15-20 minutes, that will be the difference. You can finish a simple discectomy in 30 to 45 minutes, maximum 1 hour. Okay, so you are doing a micro discectomy, you'll be taking somebody can finish, let's say apart from the Bell's curve, 2SD, 2 standard deviation, most of them will be finishing in 35 to 45 minutes. 10-15 minutes, I don't think that makes a. We are talking about discectomies. But if we are talking about canal stenosis, look at the stability that you might cause by open surgery. You are here, you are preserving the pillar, the muscles, everything is being preserved. Look about the T-lips, look about the cervical, look about the incision that you are giving and the muscular you are doing. When you are talking about you are not just talking about this, though this is
Yeah,
here
so we
in
are discussing about
but then,
discectomies here.
then yes, what I'm saying you not for beginners. Beginners, yes. Enhance your knowledge, there is some cost. Cost for the patient, cost for the surgeon. Why we are not discussing the patient, the time thing. Gradually, that patient will also benefit, not the single patient, the other patients will benefit because your expertise in CP. Think about a residency. How long would you take doing a CP angle? Think about.
Watch Godfather. Marlon Brando says, "I'll give you an offer which."
As far as the evidence part is concerned, evidence builds up but these days, it's not about what you publish in the scientific journal and what you talk about. Patient choices. A lot of aneurysms, a lot of AVMs,